This talk is really aimed at those, mainly at those who work in a hospital and especially in an acute setting. But it's something that rheumatologists need to tackle from time to time, and anyone dealing with rheumatic diseases will eventually encounter a patient who has ischemic digits. So I'm really talking from the perspective of someone who works in the emergency department, which I do, and as a rheumatologist. It often is the case that when someone with blue or blackish fingers or toes presents as an urgent case, depending upon who the admitting person is, a call goes out for a rheumatologist because we suspect this is a vasculitis. Of course, if it's a surgeon who's admitting, the emphasis might be somewhat different. So what I'm saying is that there are a lot of different causes and a physician needs to be aware of them. So step one is always to make a diagnosis. So when the presentation is of black or blue fingers or toes, one has to consider a whole range of things, and what I've got on this slide are the sorts of things that you should immediately entertain. Obviously, age is a consideration. So in young and middle life, you think about severe vasospastic disease. Raynaud's phenomenon can be so severe that digits can turn blue and even black. Antiphospholipid syndrome, antiphospholipid antibodies, APL. In middle life, one has to think rather more, sadly, about serious life-threatening disease like cancer, and that is much more the case in older people. Atheroma, emboli related to atheroma. If it's a woman, then it's rather more likely that you could be dealing with a connective tissue disease like scleroderma or lupus. And the antiphospholipid syndrome and Raynaud's phenomenon, severe vasospasm, feature as parts of connective tissue diseases. So it's in scleroderma that one is more likely to encounter ischemic digits, but it can also occur in SLE, as I will mention. So initial considerations related to age and gender, but the anatomical distribution of ischemia can also be helpful. If it affects the fingers and it's both hands, then vasospastic disease, Raynaud's phenomenon, is actually more likely than antiphospholipid syndrome. If it's fingers and unilateral, which is very unusual, that can happen in vasospastic disease, and much less likely in antiphospholipid syndrome, but you have to consider emboli. Emboli to the upper limb, really unusual, but it does happen. Toes, not fingers. Think more about atheroma, especially in middle and later life, and emboli related to large atheromatous plaques in the femoral artery, for example, more than Raynaud's or antiphospholipid syndrome, although all of these are possible. But I'm just talking about the probabilities here and making a diagnosis. If it's fingers and toes, then obviously emboli become much less likely, still possible, but much less likely, and one has to be thinking more vasospastic disease, antiphospholipid syndrome, and again, cancer. And Berger's disease, uncommon condition, mainly men, heavy smokers, and slightly controversial condition because so many so-called Berger's cases turn out to have something else in the end. The history then is also important, so you've considered the first things that come into your mind, and now you delve a little deeper, and then maybe that the whole thing will unfold. So there may be a clear history of Raynaud's phenomenon linked to a connective tissue disease. There may be a history of arthritis. It may be the initial presentation of someone. There may be clinical features in the history of lupus. And then you have to make sure that there are no other diseases to consider. Comorbidities, diabetes with peripheral vascular disease, which is something that you don't see as much in this part of the world as we do in Europe. When I worked here, I simply did not see amputees hobbling around the diabetic wards as you do in Europe, so for one reason or another. Heart disease, which is always a potential source of embolic disease, and peripheral vascular disease unrelated to diabetes, someone who's got a history of intermittent claudication, for example. And then the exam. Obviously, peripheral pulses, bruise over the major vessels, atrial fibrillation, the Allen test, which is simply a simple test to see whether there is rapid revascular, when you squeeze the artery, whether the color returns quickly or not. Digital pulp atrophy will provide a clue to previous vasospastic disease. Neurocapillaries, where there's a history of Raynaud's phenomenon and the nail base is erythematous and where there are abnormal capillaries, it suggests strongly that one is dealing with a connective tissue disease, more likely mixed connective tissue disease or scleroderma. Is there a rash? Is there clear evidence of sclerodactyly, again pointing to scleroderma? Are there telangiectasia, again suggestive of scleroderma? And a good examination of the lungs and the so we're looking here for clues of the underlying disease. So here's a patient who has previously presented with ischemic digits, still has ischemic digits, and has lost already the tips of fingers. This is a patient with scleroderma. You see the pigmentation there related to the scleroderma. This is another patient with severe Raynaud's. The